Hi everybody, my name is Sheree Saßmannshausen, and on behalf of my co-authors Nazmun, Ontika, Fabiano, Pinatti, Mark Rouncefield and Volkmar Pipek, I'm going to present our paper Amplifying Human Capabilities in Prostate Cancer Diagnosis, an empirical study of current practices and AI potentials in radiology. In Germany, prostate cancer is the most prevalent cancer among men, with an increasing tendency. This contradicts the limitation of available radiologists, who represent only 2.3% of all doctors and are therefore a critical resource. In fact, there are around 70,000 new cases of prostate cancer per year. But there are just around 9,535 radiologists who are also responsible for diagnosing other diseases besides prostate cancer. This scarcity raises concerns about having not enough medical professionals available to address the growing healthcare demands. AI could support with this challenge, as it holds significant promise in enhancing prostate cancer diagnosis for radiologists. Means radiology, with its data-intensive nature of imaging procedures, is well suited for AI applications, as AI has the ability to swiftly process large volumes of data that exceed human capabilities. Incorporating an AI assistant into radiology could enable easy and rapid informed decision-making and foster collaborative diagnosis for improved accuracy, efficiency, and consistency. We present a threefold contribution: an empirical study on radiologist practices in prostate cancer diagnosis, an informed discussion on how AI can enhance decision-making, and design recommendations and HCAI concepts for prostate cancer diagnosis. Our contributions aim to address two research questions. First, what are the unresolved challenges faced by radiologists in current practices concerning prostate cancer diagnosis? And second, what potential does AI hold in enhancing radiologists' current practices for prostate cancer diagnosis? In our related work, we outline the intersections among AI, radiology, prostate cancer diagnosis, and human-centered design. Studies have shown that AI systems can provide better diagnostic performance over humans in less time, but without fatigue, and reduce human flaws, limits, and errors. Research exists in similar healthcare settings about attitudes and potentials toward AI in radiology and pathology to increase efficiency and accuracy. For instance, AI is often being used to detect breast cancer. There are also several studies on the use of machine and deep learning for the detection and segmentation of prostate cancer, but the usefulness differs in different prostate zones, which needs to be considered. For seamless integration into real-world medical practice, researchers emphasize the importance of keeping humans at the heart of AI development. Engaging users in the design process can contribute toward more ethical, adaptable, and useful AI systems. We learned that HCAI design, ideation, early prototyping, and problem formulation needs to be considered to overcome the tension between user-centric and technology-centric design approaches. Furthermore, explainable AI can help accelerate the adoption of AI in medicine. Some studies emphasize the importance of visualizations in increasing transparency, which can have a positive impact on the user's trust in the AI system, leading to a fair, responsible perception. To answer our research questions, we followed a human-centered AI approach and adopted a practice-centered design process by involving practitioners in the design process. Through this human-centered approach, we understood user needs and pain points. We collaborated with diverse stakeholders, including AI developers, HCI researchers, patients, and medical experts such as radiologists and medical technical radiological assistants, but our main focus was on radiologists. To explore the real user environment, we conducted a qualitative field research. 4 different radiology centers with medical experts as well as patients were involved. We immersed ourselves in the radiologist's work environment for 8 contextual inquiry sessions to directly observe users in their work settings and engage with them within 3 to 5 hours per session. In addition, we used interviews to ask more about the radiologist's insights and needs. For our data analysis, we employed a thematic analysis approach. This phase involved the collaboration of our interdisciplinary project team comprising HCAI researchers and AI developers. For data decoding, we used the mirrorboard to create an affinity diagram, which served as a vital bridge between raw data and actionable design concepts. Our data analysis revealed a multifaceted understanding of radiologists' current work practices to address the first research question. This includes an overview of the diagnosis procedure, the MRI interpretation process using a classification scheme called PIRATES, diverse approaches, the use of different artifacts and systems, and external communication and collaboration. Drawing from our fieldwork, we have divided the diagnosing process into 5 phases. First, the patient inquiry, in which radiologists engage with patients before the examination to explain the procedure and gather relevant medical information. For the image acquisition, patients are handed over to the MTRAs to conduct the MRI exams, with different image sequences and different perspectives. The image interpretation is the main task of the radiologist, aiming to detect and assess the presence of lesions. I will explain that later. The results are then reported. Rather than having an automatic data transfer, the most radiologists use a dictation system to dictate all measurements and calculations derived from MRI images. In general, reporting is very time-intensive and might be error-prone. The verification phase is optional, not a routine of the radiological practice. Just in critical cases, radiologists communicate with other involved doctors whenever necessary. They often request any feedback, for instance the biopsy results, to evaluate their findings, but they often don't get any response. Prostate MRI interpretation is complex, leading radiologists to rely on PIRATES guidelines to score lesions for the likelihood of prostate cancer. MRI images for each patient contains different sequences from different perspectives. Not every lesion can be rightly characterizable in every sequence. So it is important to look at all the different sequences and to compare them to find correlations. Depending on the prostate zone, which is sometimes hard to distinguish, lesions might be more or less critical. Furthermore, radiologists measure manually the prostate gland by using a digital distance meter on the MRI and calculate the prostate volume as well as other values manually by using their private calculator app. While double analysis can have advantages and is recommended by guidelines, its practical implementation is challenging due to resource constraints, including time limitations and a scarcity of radiologists. One radiologist suggested that about 10% of all findings should be subject to blind re-evaluation by others. He said the findings would then be so much better if they were looked at again in pairs. But in our study, just one radiology followed a double analysis policy by having 2 radiologists assess each case. However, we observed that the second radiologist often has limited time for a full analysis. So the first radiologist provides a summary to the second, potentially leading to a biased perspective. All the radiology centers use a similar infrastructure. Overall, as you can see on the image, we could witness the complex and demanding nature of a radiologist's workflow as they navigate between multiple digital and physical artifacts. We also observed that radiologists also rely on paper-based materials. For instance, a prostate sector map is used to mark lesions for referring doctors. We learned that radiologists first print these maps and then manually draw affected areas by hand to mark the locations, which takes up extra time. To tackle the presented challenges and to address our second research question, we defined design implications and AI concepts to support the prostate diagnosing process. Our findings include the radiologist's attitudes and trust towards AI, AI-driven visualizations, the use of automation for manual tasks, a hybrid intelligence approach, and ideas for a multidisciplinary communication and decision support tool. All the radiologists viewed AI as a promising avenue for enhancing their diagnosis capabilities, as they envision AI systems offering pre-diagnosis and aiding throughout the diagnosis journey by increasing the precision, efficiency, and uniformity. As such, we propose that the second evaluator need not exclusively be human. AI could act as an assistant, generating preliminary or supplementary findings, as radiologists state that AI is not intended to make a final decision, but it can support and draw attention to certain areas. We should not replace human performance, but enrich their ability to diagnose by providing them with a second opinion through AI as a concept of hybrid intelligence. So humans still need to be involved in the process, as their experience and the consideration of the patient's context are required, and the decision always lies with the human entity, the radiologist. Asking about trust, many radiologists mention that they need to test the system first for its accuracy, and depending on the success, they would trust the system accordingly. Now I will show more of our design concept regarding AI-driven visualizations for prostate diagnosis. Our design concept aims to alleviate radiologists through the integration of AI, which involves using image recognition for the identification of the prostate location, segmentation of distinct prostate regions, detection and localization of potential lesions, and classification of identified lesions following the pirate scheme. One radiologist told us the AI should be a workload reduction, and the focus should be on lesion detection and classification. The images show the current stage of the AI prototype. We can see how the AI can distinguish and segment the prostate zones, as well as highlight identified lesions by outlining around the lesion's border. We learned that prostates vary in shape and size, making it challenging to rapidly discern the prostate. So while the AI can automatically detect the prostate's boundaries, it reduces time and aid in accuracy. So our result will suggest that various visualization methods, such as outlining the prostate and the zones, highlighting specific areas with contouring or color coding, might enhance the comprehension of the MRI. For instance, while tumors are less common in the transition zone, radiologists often struggle in locating them, so this is where AI might support well. For the lesion classification, their size is used to determine the severity. This could also be calculated and visualized by the AI, so that a pirate score is suggested, as we manually include it here into the image. Our research showed several manual and redundant tasks, which are time-consuming and error-prone. The use of automatization could support these tasks. And as a radiologist often complain about drawing manually lesions on the prostate sector map, you can see our solution in which the identified lesions by the AI, here marked in red, are automatically transferred to the sector map. This image, as well as other AI results and calculations, could be directly transferred to the report. So in our paper, we provide insights from an empirical study with an HCAI approach, emphasizing practice-centered design, through which we gained knowledge about current practices and AI potentials in radiology within the prostate cancer diagnosis. We immersed ourselves in the field by conducting contextual inquiries and interviews. That affords us a comprehensive overview of practices and challenges faced by radiologists. And we identified specific user needs and design implications for the AI-based tool. We recognize that radiologists perceive AI as a promising avenue for amplifying their diagnostic capabilities. So we conceptualized an HCAI system to address the identified challenges. We understood that AI should serve as an assistant, fostering seamless collaboration with the radiologist, who often works alone, to provide a second opinion and to support him in making the final decision that ensures human intelligence rather than replacing it, resulting in hybrid intelligence. This can help radiologists make more efficient, accurate, and timely diagnoses. In our study, radiologists often emphasize there is no substitute for human agency, because the radiologist's experience and expertise are hugely important. Nevertheless, all participating radiologists express a positive attitude toward AI and are eager to collaborate with it. The interdisciplinary collaboration in our research team with radiologists, AI developers, and HCAI researchers help to leverage different expertise and viewpoints. Thank you for your attention. For more details, I would also encourage you to read our paper.